just over half an hour. Bretnell starts at 7:30, not 7, so I don't have 3 minutes to do this. I've got 33. So oxygen and ABGs, we did as 2 lectures last time, and we've combined them into one for a few reasons. One, to give John Feather longer at the end, Adam Feather longer in the last lecture of this series, because he's brilliant. So I'll do one of my smaller lectures on the last week. So tonight we're going to just go through oxygen and ABG in 10 simple cases, hopefully going through everything in terms of the simple interpretation that hopefully you all know already. A few of the common concerns, such as the AA gradient, base excess, anion gap, COPD patients, which everyone seems to get confused with, and non-invasive ventilation, which... so this is some super keen students, again, from my Googling, practicing ABGs on themselves. So tonight, get the needle out and give it a go. I've had one done, and it's so painful. So, yeah, try. So I've got some cakes here that I bought from Harriet. Definitely buy more in the break, but if anyone answers questions, then I'll throw the cakes to you guys. Try not to make a mess. Okay, so the first case. 68-year-old walks into A&E, mild breathlessness, productive cough, no past medical history. What would your management be? So ABCDE. Again, like I said last week, walking into A&E, 6 years, do you need to do ABCDE? Nah, it's a bit trivial, isn't it? Like if he's, obviously you have to assess that it's as difficult. This is him here. He looks pretty chilled with himself. He's just got a productive cough. If you'd walked into a GP, you wouldn't just jump into ABCDE. So again, important you say it. If you're stuck in finals, say it, because you'll get some marks. But if you can think about it, is it an unwell patient? If it is, obviously ABCDE. This, I think, you could just go history and examination. So on examination, just generally from the end of the bed, he's talking to you, no signs of distress, creps at the left base. These are the OBS. What do we think of those OBS? Anyone? So someone be confident and just go for it. We don't bite. Hypoxic, someone said. So SATs are low. Anything? And he's tachycardic mildly. Respiratory rate's high. Just say what you see. It's not too difficult. Are they the OBS of a really unwell patient? No. Okay, so you can just risk stratify this patient into slightly unwell. Which brings me on. So what oxygen therapy would you give to this gentleman if he walked into A&E, SATs of 91? Nasal cannulae. Can someone in this front row just grab either nasal cannulae? Why don't you take it? So take nasal cannulae. Or what else could we give him? Which? Hudson mask. So grab a Hudson mask while you're there as well. These are Hudson masks. Just shove that down. So nasal cannulae, you can put that down. Oh, take a cake as well. Well done. So nasal cannulae, the reason, obviously you all know what nasal cannulae. How many of you have put them on a patient? So just over half, which is pretty good. The other half of you, please put them on a patient, because the amount of you who in finals, I had this in my finals. It was exactly like this table without the cakes and the neuro stuff. And it wasn't me on the other side, it was Nigel Yateman, which was wicked. I had to wake him up when we walked in. And he helped me a lot do that. So hopefully you won't need as much help. But make sure you know how to put these on, because the amount of you who kind of have them in all weird and wonderful ways, and it just looks stupid, like you've never done it before, which half of you haven't. So make sure you know how to do that. And these are Hudson masks, so the most simple-looking mask on the table. Not this one with an attachment on, or this one, which we'll come on to. The most simple mask, just a mask, nothing else, Hudson mask. And we're happy to give these two types of oxygen therapy because he's not unwell. He's only a little bit low on his oxygen sats, and we don't need to give a really targeted amount of oxygen. So it's a variable amount of oxygen we're giving. Are we happy with that? Yeah? So we can give either or these. So for oxygen therapy, we're going to go through this. There's 2 questions you need to ask, and it will simplify all of these COPD. Should we give everything, should we give limited oxygen, or should we give a normal, full amount of oxygen? First question, is the patient critically ill, or does the patient have SATs under 85%? So these are the 2 questions. This patient is neither of them. So then you go on to the second question. Is this patient at risk of hypercapnia? Is he? This gentleman with no past medical history? Oh, sorry. Yeah, good. Well done. So, our first patient, we're still on the first case. The no past medical history, mild. So just remove this word here. The rest of it, is he at risk? No. So then we can give, so he's just a normal person who comes in with low SATs. So for these people, the target SATs are 94 to 98%. They can go higher, that's fine. This guy had 91%, not 87 like this. So you can give either nasal cannulae or face mask. You don't need to give a Venturi. And then you can do an ABG if you feel like he's deteriorating or not responding. So the difference is just basically patient choice. Some prefer having no stuff in their nose. They can get nosebleeds, and it can feel a bit invasive up their nose. And often you see them on people's heads, and they just don't really like them. So some prefer to have a mask on. It makes them feel more unwell, I think, so they embrace that. But it doesn't really matter either or. It gives a low variable amount of oxygen. It's just patient choice. Again, so another small thing. How many of you have turned the oxygen on? So it's really easy, probably half, yeah. It's really easy to go for the full whack because you just keep turning it. But for anything less, the ball is in the middle. So the line is in the middle of the ball. That equals 2 litres per minute. Not above, not below, like other kind of systems you might have used. So this is that guy's ABG, the first guy, no COPD. You put him on nasal cannulae or your face mask. Now I'm going to do all of you know the normal values for ABGs? Yeah, most of you. For this lecture, just because that's not what I'm here to do. For the other ones, I'm going to give you the normals. But what do we think of this? Fine? Yeah, anything not fine about it? So the CO2 is a bit low, yeah. So it's not fine. So be a bit more specific. So pH is normal. The CO2 is low. Why is the CO2 low? Yeah, so he's hyperventilating. And the HCO3 is, or the bicarb is normal, which shows it's nothing long-term a problem here. So yeah, you can carry on. This patient still is at low risk of hypercapnia, so you can stay with the target SATs. And they're the normal values, which we'll come on to. So you prescribe oxygen like any other medication. None of you do, none of you will, but for finals you say you should. So for this guy, he just needs his target SAT circled. It's PRN because when he gets up to 98, 99, he doesn't really need to stay on it. But then he may drop down until you treat the cause of his symptoms. You said 2 to 4 litres per minute, which is what you give on the nasal cannulae. You can't give any more than 4 just because it won't fit through the holes. And for Hudson mask, you can give more, but if you're needing more, then you need something a bit more specific and high flow. And then you sign it and date it exactly like you would any other. Okay, so next case. 68-year-old man, ambulance to A&E, very unwell. The wife is telling you he's very unwell and breathless, so obedient. And the patient has COPD, and the wife says this is similar to his previous exacerbations. So what would your management be? A, B, C, D, E. Excellent. So this is an unwell patient, so make sure you know what you mean when you say A, B, C, D, E. And then what would you do? You've done A, B, C, D, E. Then you're suddenly a doctor, so you have to do something. What would you do? Good, so you do some observations. Wicked. So I think I've got them here. So that's the unwell man. He's distressed, he's got wheeze everywhere, and these are his obs. So yeah, they're really, really bad, aren't they, yeah? We're happy this is a really unwell patient from what the history says, what the patient looks like, and what the obs say. So heart rate of 120 is not good, respiratory rate 29 is very high, and obviously the SATs of 78 are crap. So first question you ask in it is how unwell is the patient? And we're happy that he's both critically ill, yeah, or very unwell. And a few people last year said, what do you mean? Like, how do you know it's critically unwell? Critically unwell is very personal to the doctor looking after them. Basically, if you're worried, if your heart rate's above 120, then that's a reasonable shout. So obviously, a respiratory reg will be happy to deal with things by themselves much more than me or you guys would. So, but basically, if you're scared and you think they're unwell, then that answer is yes. But easily in this case, the SATs are also under 85%. So what do we do? High flow oxygen, okay? So really important you guys get this. So even though his background is COPD, even though you're all scared he might be a CO2 retainer, he's unwell, okay? So hypoxia will kill someone. So a side effect of hypoxia is death. Side effect of hypercapnia is maybe a bit drowsy, maybe a bit confused, but not death. So it's better for them to be drowsy than dead. So if either of these questions are yes, then you give high flow oxygen. But obviously you're aware that they might be retainers and they might be a bit more high risk than anyone else. So then you do an ABG. We'll come on to that. So high flow, next, do you want to come and show me a high flow? So yeah, so high flow oxygen, it gives 60 to 80%, and it should only be used short term. Okay, so how many of you have put one of these on? I'm surprised, more than I thought, because usually unwell patients get these and you don't usually let the fourth or final year students do it, but that's cool if you have. If you haven't, then just make sure you do it. So either put them on a patient or just make sure you know how to do it, because you have to fill this reservoir up. So every time the patient breathes, they're getting this reservoir of pure oxygen, and you need to know how to fill it up. So you press down on this one-way valve, it fills up. You squeeze it to show it's got no leaks. You fill it up again, and you put it on the patient. But make sure you've done it, because again, it looks stupid if you've said the right thing. This yeoman suddenly woke up and you said he needs high flow oxygen, and then you don't know how to do it. So make sure you do that. Okay, and then you've done an ABG. So what are we thinking here? Good. So type 2 respiratory failure. With some compensation. Anyone else? ABG? Just okay. So respiratory acidosis. Okay. So we're going to go through all components of this. This kind of pulls it together. The way I like to do it is the stage number 1 is the patient unwell? Yes, because that helps you to kind of set your mind into the right state. Then look at the oxygenation. So this patient's got a low, normal or high oxygen. That's low, yeah. Then you look at the CO2, because then you can work out if it's type 1 or type 2 respiratory failure, which is really important and often forgotten. So this patient's got type 2. Yeah, we're happy with that because it's got 2 problems. Low oxygen, high CO2, so type 2. Then you move on to the other part. So the pH is low. Yeah, so it's acidosis. And what's causing that acidosis? CO2 being high causes acidosis, so it's a respiratory acidosis with some compensation because the bicarb, which is alkalotic, is high. Does that fit with this patient, is the last question you should ask? Yeah, because they've got chronic problem, so bicarb is a chronic buffer or a chronic compensatory mechanism, and so that would fit that they're chronically got a compensatory mechanism, but they're acutely unwell, so their pH is not normal. Okay, so that kind of brings it all together, but we're going to go through each part of it. So in terms of oxygenation, just a few small points. So normal on-air oxygen should be above 10. If they're on oxygen, it should be 10 kilopascals less than the percentage of oxygen they're on. So that's an easy example. So if they're receiving 15 litres of oxygen and their oxygen is 11, that's not normal. That shows there's a respiratory problem going on, because the 15 litres of oxygen delivers, in the non-rebreathe mask, would deliver about 50 to 60% of oxygen. So you need to have 10 less than this, so between 40 and 50. It's not usually that good because obviously everyone has some degree if they're acutely unwell. But anything above 25 or 30 would be reasonable. Does that make sense to everyone? Yeah, so what's normal on someone who's on air and on oxygen? It's really important. And then we've talked about type 1 and type 2. So next case, 3. So A&E breathless, COPD, but says he's had previous ITU admissions with problems with my gases. What would your management be? So probably A, B, C, D, E. History, they're the OBS. Medium, good or bad, really bad? Medium, yeah? So COPD would expect and accept SATs of between 88 and 92, so 87's kind of borderline. Respiratory rate of 20 is probably similar. Heart rate of 105 in A&E, probably a lot going on. He's come to A&E breathless, so you'd expect to be a little bit high. So I'd say that's a medium picture. So answer to that? Nah? Unless you're scared, then it's yes. So it's fine to be scared, and if it is, then it's yes. But no, I'd say. So is this patient at risk of hypercapnia? Yes. Happy? All yes. So now they're not critically ill, so you don't need to give them high flow. You can decide between the Hudson and the Venturi, but they are at risk. So we'd give which? Venturi. Wicked. Well done. So Venturi. So does someone, do you want to come and pick? It's difficult, this one, because which colour Venturi are you going to pick? Oh. Green. So he's gone for green. Any advances on green? Blue. All of them. Okay, so it's really so it's difficult to remember these. I don't know who chose blue, white, yellow, green, red, green as the order, but they did. Thankfully, on all of them, they've got what percentages on the side, and they've got how much oxygen you need to put in your through the oxygen. So blue. So all you guys need to remember is blue, because we always start with the lowest one if we're using Venturi. The rest of them you can work out over the coming years. If you forget, if you just look at Yateman with 2 of them, he'll be like this one and you pick this one, like he did in my week. But yeah, just pick blue. And again, you can't, the problem is, again, that these 2, the Hudson mask, this funky type of Hudson mask, and this one look quite similar, but obviously you can't connect this one. So make sure you're happy. I'll leave these out, you can look at them. But make sure you're happy that which connection it goes on to, again, because that looks silly. But blue is, and then the rate of oxygen depends on which Venturi you're using. So you don't need to remember this, it's all on the side, but just remember blue. And And it gives, like we said before, this now gives a fixed amount of oxygen depending on which mask you use and which connection you use. So that's good for a patient you're worried about. Again, prescribe it, so 88 to 92, continuous, and you've now said it should be 2 litres because it's this Venturi. Squiggle, squiggle, sign, date. Oh, these have all gone wonky. That's a shame. Okay. Bear with the wonkiness, but this is our patient you've now put on a Venturi and you've done an ABG. These are the 3 options. This is the oxygen, obviously. I don't know if I... No, I don't. So yeah, this is one option for her ABG, this is second option for her ABG, this is third option. For each option, what would you do in terms of her oxygen? Okay, so the first one up here. So this one. So it's on 24. Reduce it, what, to air? It's like 21's there. So let's go through it. So the oxygen, we happy with that? Yeah, it's reasonable. So we said he's now getting 24%, 10 less, 14. He's doing pretty good. pH, it's fine. It's normal. It's not fine, okay, not right. It's normal. Where are we next? CO2 is slightly high, and the bicarb. Okay, so now this patient has that confirmed that they're at risk of hypercapnia? Yeah? And we're happy with the oxygen? Yeah? So we stay with these targets, and more, we stay with the blue Venturi. You happy with that? Yeah? So just because these are different, if the oxygen was lower, so say the oxygen was 8 or 9, but the pH was normal, CO2 was elevated, then that's when you start to what? Go up with the, I don't remember which is next. Does anyone? White, yeah, okay, white. So you go up the Venturis. So you need to give them more oxygen. And when you go up the Venturis, what do you do? So retest, how do you retest? Another horrible ABG. So you keep doing it every 15 minutes, 20 minutes will show a reasonable response until you're happy. Obviously, it goes without saying, if they suddenly become well, and then you're not worried about them, you don't need to keep doing it. But, and you can look at their oxygen sats on their sats probe, but that isn't very accurate. If they're unwell, you need to just keep doing horrible ABGs. The next one here, oh, this one. Quickly. So pH normal, CO2 normal, oxygen normal, HCO3 normal. So what do we? Discharge. Do nothing. Wicked. Yeah, so, yeah, you could discharge them. Send them home. Get them out. No, so they're now normal. They're not acidotic. So they're now, are they at risk of hypercapnia? Has that ABG shown that? They're not, are they? Because this guy's not retaining CO2. So you can just put him on a normal mask or keep him on the Venturi, whichever you prefer. But yeah, that's pretty reassuring. So you can treat that as a normal patient then. And then this one here. So start with oxygen, low, pH, low, so acidotic, more technical. CO2, high, CO3, high. So this is really crap, isn't it? So what do we do here? Panic, yeah? Yeah, why wouldn't we go up the Venturis? So he's retaining, so if you increase the oxygen, he's more likely to retain more. So you'll fix this problem, but you won't fix this. Why don't we just reduce the oxygen and sort out his CO2? Because he dies. Yeah. So you need non-invasive ventilation, so you need help, so call ITU quickly. But what do we do with the oxygen in this guy? So if you've called, they'll say there'll be 5-10 minutes. Switch. Non-rebreathe, but then you'll push them really hypercapnic. Do you stop the oxygen? No. So just carry on. If you're worried he's reducing his sats, then non-rebreathe. Otherwise, just carry on with that and wait nervously. Look busy, do something else. Go and get a coffee. Tell your reg, run, hide, any of those. Cool. Some patients will have these oxygen alert cards which will tell you what type of respiratory failure they have, what venturi they should use. Makes life really easy. Still, if they come in unwell, you need to give, really unwell, then you need to give, but you can have a slightly lower threshold to putting them on a venturi. What's that? CPAP mask? No. Trachea mask, yeah. So that's all. It will be on your table, so make sure you don't pick that up unless they have a tracheostomy, and do. And that's all you need to know. Treat it otherwise as normal. Okay, we're only case 4. We've got 6 minutes. Okay, we might have to come back to this, but we'll keep going until Mr. Bretnell arrives. So case 4, this is a type 1 diabetic. It's been vomiting, respiratory rates high. These are the OBS, which are not very good. What would you expect as ABG? So I think that's really useful to do. So metabolic acidosis would be a reasonable guess, and true to your word. Does that fit? So acidosis, bicarb 7. How low is that pH? Very low, so this is really bad. But yeah, so I think it's quite useful, because they'll give you all this blurb, it's quite useful to guess what the diagnosis or the ABG will show. It just helps a bit. Blah, blah, blah. Has he got any compensation? Do they usually have compensation? Yeah, with what type of breathing? Or smile. Yeah, cool. So he's got respiratory. And then you'd obviously want a BM and urinary ketones. Who are these 2 people? Quickly shout it loud. Henderson, Hasselbank. Yeah. That's all. Next. So yeah, unless you're a geek, you don't really need to know anything more than those 2 players. But yeah, just take your time. So there's 2 different processes, a metabolic and a respiratory. An amount of times that you jump to the big red respiratory, and then you miss out the metabolic, or the other way around, because it's really obvious. And then you will miss mixed or compensatory patterns. Base excess is the same as bicarb, just usually changes quicker, but for all intents and purposes gives you the same type of information. So high base alkalotic, base excess high is metabolic alkalosis, as you all knew. So compensation. So you'll get an initial problem, and then your body compensates. So the respiratory system compensates quickly because you can breathe off carbon dioxide quickly, and then metabolic is slow. So how many of you were here last week with Dr. Flood? Probably most of you. So I think he tried to explain this. And so I think he overcomplicated it a little bit with his divided by 7.2 or whatever he did. But I think this is all you need to know, and it's really important when you're thinking about compensation. So primary pathology, metabolic acidosis, we'll use this as an example. So you're happy that then the patient will compensate quickly with respiratory, blowing off the carbon dioxide. You're happy with that? Yeah? So I did this, really. Yeah. So that's the compensation. So the carbon dioxide goes down. So this will make the pH go up or down? So down, so acidosis. And this will make the pH come slowly back up. So, see what I did there? Took me hours. And the point I'm trying to make here is that your compensation, you will not overcompensate. Okay, so you can see he's compensating to the lower end, and if he compensates, then he'll be on the lower end of the normal pH. So you will not get a respiratory compensation, metabolic acidosis, so an acidotic pH, compensated back to normal. You will not then suddenly become alkalotic. Your body will not overcompensate. So it will be on the lower end, so it will be 7.4, i.e. in the middle, or lower. So you might get 7.39, 7.38, 7.37 if they've compensated. You will not get 7.45. So if you look at the pH and it's normal, but it's 7.45, then you can't have this picture. It can't be metabolic acidosis with hyperventilation making you nearly alkalotic. It will be on the lower end of normal. Does that make sense? Yeah? I don't think you need to know exactly what it should be by dividing it by 7.2 or however he did it. I think this is enough. So hopefully that makes sense. Does that not make sense to anyone? No? Good. Okay, so this is the same case again. These are using these you did. What's the anion gap for this patient? Does it fit? Does it fit with our diagnosis of DKA? Someone be arrogant and just shout out. 23. Wow. Is that high or low or normal? High. Does that fit? Are they guesses? Well done. Very good. So, so you only do it if they've got metabolic acidosis. You shouldn't do it an anion gap and anything else. And it measures the anions that we're not measuring. So you take away the positive ion, so the sodium, from the negative, which is the chloride and the bicarb, and you get a number. And normal is between 6 and 12. If you have a high anion gap, so 13, 14, 15, or 23, then it's something in your body is producing acid to bring the anion gap higher. So in our patient, it was the ketones that we diagnosed ketoacidosis. So this was bringing his anion gap higher. So that fits. A normal anion gap is where you're excreting more of alkaline. So it would be normal between 6 and 12. Does that make sense? Pretty simple. 2 bits you need to remember. This little equation here, and between 6 and 12. And high is when it's produced. Yeah, please.
Don't you add the potassium?
So don't you add the potassium is the question. So you can, if you're, the only people who will ITU and respiratory, like regs, the reason us mere mortals don't need to is because we're talking about 136 and 101 for these. So whatever the potassium isn't going to change it much. So we don't, mere mortals don't. You're right to say if you're doing like the super anion gap, then they do. But for your exam, you don't need to. And this anion gap of 6 to 12 is for without the potassium. Happy? Yeah. Mr. Bracknell? Oh, he's behind me. Wicked. Okay, we'll do one more then. So smoker walks in. This is the ABG. Now this one's a bit boring. Let's do another one. So this is a simple one. So type 2 respiratory failure, metabolic acidosis. And what would you expect? AA gradient to be normal, low, or high? High? Okay, so AA gradient evaluates or looks at what's the cause of your low oxygen. So again, you don't need to do it unless, you don't need to think about it unless they're hypoxic. And it looks at the difference between the alveolar and the arterial oxygenation. Don't really need to know much more than this. So if they'll say, they won't ask you to work it out, they'll just say it's high, or if they're mean, they might say it's 15, which you need to know it's high. And if it's high, it's something in the lungs that's causing it. If it's normal, then it's something outside the lungs that's causing it. Okay, so we're going to do, let me just have a quick look. We'll do one more. Actually, we're nearly at the end, so I'll just finish this one. Okay. Okay, anyone? So go through it. So the first thing about oxygen, low, type 1 or type 2 respiratory failure? 2. Karen, yeah. Respiratory acidosis? Mixed, yeah, well done. So mixed acidosis, do we all get that? So the bicarb is low, so the alkaline bicarb is low, so that's causing an acidosis, plus the CO2's high. What can cause that? Pneumonia and sepsis together. Yeah? More commonly? So if they're chronic COPD, so chronic will give you this. If they become unwell, and then they become, chronic COPD will give you the respiratory picture. They become unwell and they have high lactate. They can get a lactic acidosis, which is metabolic. So they get an acidosis from their chronic COPD and an acidosis from their lactate. So just work through it. It's getting the picture is not difficult. But the amount of you that will say just one problem here, or they'll say that it's a compensatory just because you see there's 2 problems. You just really need to work through each one and does it all fit? So that's a mixed picture. There are all the causes. We'll just finish because it's nearly there. So a nurse calls you on the 5th of August 2016, didn't change that, which is your first day. 68-year-old COPD patient, unwell, is now short of breath. Doctor, should I give CPAP or BiPAP? What would you do? So we've got CPAPs, we've got BiPAPs. Hands up for CPAP. Hands up for BiPAP. Hands up for something else. Yeah, you're right. Cakes for all of you. So yeah, you wouldn't over the phone say CPAP, BiPAP, and they'll just ask you that. So you go through A, B, C, D, E, look at the notes, what are they usually on, what's the diagnosis? Bit of a trick question, but of course you would get help. So CPAP, BiPAP, I'll just go to the simple explanation. So CPAP Continuous is for an oxygenation problem, i.e. type 1 respiratory failure. It just blows oxygen like this, really. So you're just getting oxygen at all times. BiPAP helps to ventilate, so you're going in and out. So for type 2, so COPD patients, you give BiPAP. So the answer would have been BiPAP if you had to choose one. 9 and 10 read at home, asthmatic and quite well post-op patient. So yeah, just with ABGs, make sure you use a structure, whatever structure you've got. With oxygen, if they're unwell, give high flow oxygen and then worry about the COPD later. Any questions? No, wicked. Thank you very much.